Allow me one
Yes, sir.
minute.
I
Let me
have
check.
stopped
Thank
share.
you, ma'am.
I have stopped
Thank,
screen sharing.
thank you, ma'am. Thank you very much. Thank you. You'll be going second in about an
Thank you.
hour's time. You can remain in the Zoom only.
Yes, sir. Yes, sir. Thank you, sir.
Friends, good evening, everyone. Uh, Warm welcome to all of you for joining this evening. Today we have yet another important exam case discussion, the obstructive jaundice and carcinoma lip. The first case is kindly contributed by Professor Sinha from Rajendra Institute of Medical Sciences, Ranchi, to be presented by Dr. Arunav. The second case is kindly contributed by Professor Saravanan sir. The presenter is Dr. Tamil Mari. He is going to present a case of carcinoma of the lip. Friends, we have a galaxy of speakers here. We are expecting few to join. We warmly welcome Professor Amit Gupta, the Professor of Surgery at AIMS Rishikesh. She is also in charge of the HPP unit. We have Professor Vaibhav Sutaria from the IKTRC, and she is a liver transplant surgeon and HPP surgeon himself. We have again Dr. Pratish, kindly recommended by Dr. Hidaya Nag. He is a senior fellow at GB Pant Hospital post MCH. And we expect Professor Venkatraman Reddy sir and Professor SP Mishra sir to join us. Professor Chetan Kantaria will be joining
I'm here,
little
sir.
late. Oh, I'm sorry, I
I'm here.
didn't see you, sir. Very sorry. Thank you for joining, sir. Thank you.
Thank you, sir.
So, without much ado, we start the presentation. Dr. Arunav will be presenting the first case. Dr. Arunav, please introduce yourself, your unit head, your professor and head of the department. Start your presentation. Good
Yes, sir.
luck to you.
Thank you so much, sir.
Yeah. Faculty, please take over.
Yeah, Aruna, we will start, please.
Yes, sir.
Share your screen.
Sir, is my screen visible, sir?
You are good to go, ma'am.
Yeah.
Dr. Amit, you wanted to tell something, sir?
Aruna, I can't see your slides.
Sir,
It's visible, sir.
We give some time. Probably his connection is little slow.
Yeah,
I
we
also
can see.
had
We
some.
can
But
see.
it is visible, sir.
Dr. Kagnabal,
Slides
Yes,
can
are
you
please
see
go.
visible.
his slides?
Sir, we are all able to see the slides, sir. I'm not sure. Zoom is having some patchy issues today. Initially, I also had the problem. Do you wish to log in and log out?
May I try resharing it, sir?
No,
You
that's
can do,
fine.
You
Dr.
stay as
Arnav.
it is.
Sir.
Try it,
You stay as it
Doctor.
is.
Okay.
Except I've reshared it again, sir.
Yep. Professor Amit, sir, are you able to see, sir,
Good
now?
afternoon.
Okay. What is happening? I'm unsure.
We are able
Amit,
to
sir,
see the slides.
others, Dr. Vaibhav and others, are you able to, Dr. Prakash,
Yeah,
SP Mishra, sir, others?
yeah. Yes,
I
sir.
can see.
We
I am
are
able to
able to
see.
see, sir.
Okay. Dr. Amit, sir, your connection, I think, probably is need to be rechecked, sir. I think he has
Okay.
some
Meanwhile,
topic.
Arnav, don't waste time. Please start. Please start.
Yeah,
Yes, sir.
please
Yes,
start.
sir.
Don't waste
Sir.
time. I will see your slides.
Sure,
Sir.
sir. Sure.
Sir, thank you, sir. Sir, my name is Dr. Aruna Roy. I'm a general surgery resident, third year, in the Department of General Surgery, Rajendra Institute of Medical Sciences, Ranchi. I'm in Unit 1 under the aegis of Dr. Professor D.K. Sinha, sir, who is the HOD of my department as well. I'll be presenting a case of obstructive jaundice. Case history. My patient, Mrs. X, 70-year-old female resident of Ranchi, homemaker by occupation, belonging to low socioeconomic status. She presented with 3 complaints of right upper abdominal pain for 1 month and yellowing of eye, skin, and urine for 2 weeks. History of present illness. My patient was apparently well till 1 month ago when she noticed a dull aching pain in the right upper quadrant of her abdomen. The pain is dull in character, radiating to the back, continuous, mild to moderate in intensity. It is not related to food intake. There are no aggravating or relieving factors. She also presented with yellowing of her eyes and skin since the last 2 weeks. It was insidious in onset, progressively deepened. She also noticed dark-colored urine and clay-colored stools along with yellowing of her eyes and skin. It was associated with generalized itching, which worsens at night. There is one episode of black eye stools passed 1 day back. There is
Arnav, I will
Yes, sir.
just interrupt here.
Yes, sir.
See, just don't write yellowing of her eyes and skin. So please mention here yellowish discoloration, right?
Okay, sir. Okay, sir.
And then you mentioned that homemaker by profession. So just say a patient is a homemaker, right? Don't say it is a profession, right?
Okay, sir.
Sure. Proceed.
Yes.
Now your slides are visible.
Yes, sir. Thank you, sir. There is history of loss of appetite and unintentional weight loss present in the last 2 months. There is no history of similar episodes in the past. There's no history of waxing and waning of the jaundice. There's no history of fever, chills, or rigor. There's no history of nausea, vomiting, abdominal distension, or unintended. I think unintended weight loss has been falsely mentioned here by mistake, sir. There's no history of chest pain, difficulty in breathing, or hemoptysis. Past history. No history is suggestive of hypertension, diabetes, TB, COPD, asthma, or thyroid disorders. There's no history of liver disease in the past. No history of past blood transfusions or chronic drug intake. No previous surgical history. Personal and family history. My patient is a married female with 2 children, non-vegetarian diet, and normal appetite. She had normal bowel and bladder episodes prior to this, but noticed pale stools and dark urine recently. She has adequate sleep pattern. There's no history of drug allergy or addiction. No chronic drug use history. There's no history of similar complaints or cancer-related deaths in the family. Menstrual history. She attained menarche at 13 years and menopause at 55 years. She's a P2L2, and all of her children were delivered by a non-vaginal delivery. The last childbirth was 45 years ago. She had regular cycles, 28 to 30 days apart, lasting 4 to 5 days. There was no history of menorrhagia, dysmenorrhea, or intermenstrual bleeding. She's not on any drugs for hormone therapy or contraceptive use. Summary. My patient is a 70 years postmenopausal female presented with complaints of pain in the right upper abdomen associated with progressive jaundice, itching all over the body, high colored urine, passage of clay colored stools, and 1 episode of melena 1 day ago. Patient has history of loss of appetite and unintended weight loss with no history of prodromal symptoms.
Aruna, did patient
Yes, sir.
tell you that in presence of jaundice, she passed melena?
Yes, sir. Recently, 1 day ago, while she had jaundice.
She was jaundiced and then she passed blackish stool as per your statement.
Yes, sir.
Suppose even if there is a melena in a patient of jaundice, so what should be the color of stool then?
Sir, usually the classical description is a silvery colored stool, which is when blood is melena is mixed with clay colored stool, sir.
Okay, go back.
No,
What do you understand by insidious
sign?
onset?
I'm sorry, sir.
No,
What do you mean by insidious
as?
onset?
Sir, insidious onset as in it wasn't abrupt and she did not notice it when it was happening. She only noticed it much later when the jaundice was much more deepened, and it was pointed out by her family members.
When you get the silver stools,
Yes,
you
sir.
know what is the sign called as? What is that called as?
Sir, I'm sorry, sir. Silver stools.
Yeah. If you get the silver stool, which means there is a clay colored stool along with the blood is there. You know what is
Sir.
that sign called as?
I'm not sure, sir.
It's a Thomas sign.
Okay, sir.
Okay, this is called a Thomas sign. Yeah. Yeah, go ahead. Yeah.
Sir. Shall I go ahead with
No, hard enough, right. This is
Yes.
Dr. Sahai. Right, I just got a few questions.
Yes, sir.
Let's go back to your first slide.
Yes, sir.
You said low socioeconomic group. How did you
Yes,
decide
sir.
she's of low social? What are the factors you take in socioeconomic groups to
Sir,
decide?
we take the family income divided by the number of family members in the household, sir.
So who all are there in the house?
Sir, in her family, sir, it is her husband, her two children, and her grandchildren, sir.
So there are quite a few people, right?
Yes,
Okay,
sir.
why is socioeconomic status important here?
Sir, usually periampullary CA has been seen to be more in patients of lower socioeconomic status, sir.
Is that so? Is that so? Not really. More important is that whether they can afford the treatment or not, whether they can understand the. Okay.
Yes, sir.
Okay. Next slide, please.
Yes, sir.
Okay, pain. That's fine. Why do you think this pain has happened? What's the cause of this pain here?
So the pain can be due to stretching of the capsule of the CBD, sir, corn-bile duct, sir,
Capsule of
or it can
CBD.
be.
No, hang on. Capsule of CBD will cause a dull aching pain with it. And is there a capsule there?
There is no capsule, sir, but stretching of the CBD would cause a pain, but then it will usually cause colicky pain, sir. Or in my pain, since I'm suspecting a malignant etiology, sir, I think it is due to the involvement of the nerve ending, sir.
Are you talking about
Which nerve?
biliary colic?
Yes, sir.
So is biliary colic colicky pain actually? In classical description,
No,
is
sir, it is not.
biliary colic
No, sir, it is not actually a colicky pain, sir, because there is.
So sir is asking why. Sir is asking what you think is the cause of pain.
So I think it is because of the involvement of nerve fibers and nerve endings, sir.
Which nerve fibers?
So nerve fibers of the celiac plexus, sir.
So that will give rise to pain in the right upper quadrant. If at all they are involved, so patient will be having pain predominantly in the epigastric region and back.
Yes, sir.
Right?
Yes, sir.
And your starting complaint for your patient was dull aching pain.
Yes, sir.
And later on she developed jaundice, right?
Yes, sir.
So you want to take us to the diagnosis of cholecystolithiasis straight away? But why patient will have dull aching pain in that?
Sir, in my patient, sir, I'm suspecting that she did not notice her jaundice till much later, sir. We are suspecting
No,
that.
Arnav.
Yes, sir.
Look, we just want you to tell us the causes of pain in the upper abdomen, upper right upper quadrant, or maybe epigastrium, right?
Yes, sir.
What could be the causes of pain in this
So
case?
it may be, sir. It may be due to cholecystolithiasis, sir.
Okay,
It may
fine.
be.
What else?
So it may be due to pancreatitis. It may be due to cholecystitis. It may be
Right.
due to.
So now you're coming up with the proper ones. No? Nerve involvement is a very late situation, isn't it? It's very late.
Yes. Yes, sir.
Right. So
Yes, sir.
they can have concomitant pancreatitis, they can have concomitant gastritis, right? All
Yes,
these kind
sir.
of things, phalangitis, all these kind of things will lead to this kind of pain. Okay.
Yes, sir.
Right. So radiating to the back, she must be having some form of pancreatitis around.
Yes, sir. She must have having some a degree of pancreatitis.
Okay. Next slide.
Yes, sir.
Like sir said, yellowing. Just make it yellow discoloration. Yellowing means
Sir.
she could be getting ripe.
So I will.
Okay.
I'll just correct it.
We've lost your.
Sorry, sir.
Okay. Any history? Then let's just leave it. Don't do it just now. Don't do it just now.
Okay, sir.
You can do it later on. Yeah.
Yes.
Any history of hematochezia, hematemesis?
There's no history of hematemesis or hematochezia, sir.
Okay. Just one episode of
Black tarry stools. Yes, sir. One episode of melena.
Now, did her symptoms improve after this episode of melena, or did she remain the same?
So her jaundice has slightly lessened, sir.
No, you can't. Look, Arnav, the patient cannot appreciate a slight decrease in jaundice, right? What are the ways that she would say that you think that the jaundice has improved?
So she could say that her urine is slightly less deeper in
No,
color, sir.
no.
Or
Appetite returns. She general sense of well-being, right?
sir.
So you got to say that. Is it
Okay.
associated with it, that or not?
Yes, sir. Definitely, it is associated with
Okay, next slide, please.
chicken in appetite.
Next
sir.
slide, please.
She can
History of waxing and waning
she
of
can feel
jaundice.
symptomatically better.
Yes, sir. She can be symptomatically better after passing after the episode of melena, sir.
Okay. Chills, rigor, waxing and waning of jaundice, chest pain. Okay, next slide, please. Okay. History of liver disease. What liver disease are you looking for?
Sir, any form of hepatitis or chronic liver disease or cirrhosis, either
Okay, next slide,
either
please.
alcoholic or
Okay, next slide. Next slide. Next slide. Okay, you said her sleep is normal, and you previously said she's got itching all over, and that more at night. So you
Sir.
think her sleep would be normal?
Sir, I meant that her sleep pattern was normal prior to the onset of symptoms, sir. She had
Okay.
adequate sleep pattern before this, but
Obviously,
currently it
obviously a
is
sleep
disturbed.
pattern. Look, Arnav. Obviously, a sleep pattern would be normal. We won't think we expect her, right? There's nothing. So you don't write this out. If there
Sir.
is itching, obviously, why is there itching?
Sir,
What is the cause of itching?
So the cause of itching in obstructive jaundice is deposition of bile salts and release of histamine, which causes the itching, sir, in the skin.
Excuse me, I couldn't get you.
So deposition of bile salts in the skin, sir, and the release of histamine, which
Okay, that's
causes the
fine. That's
itching.
fine. Okay. Next slide, please. Okay, just back. Contraceptive use. She is 15 years post menopause. Why contraceptive use? You think she would be taking contraceptives?
No, sir. But it is important. So even postmenopausal also patients are put on contraceptives for.
They're not contraceptives. They're not. That's a
You mean
HRT,
HRT?
hormone replacement.
Estrogen, yes, hormone replacement therapy
Right.
containing only
So it's
estrogen.
not. Don't say contraceptive. What's the difference between HRT and contraceptive? What's the difference between the two?
So the
Lot of difference. Go
yes,
ahead.
yes, sir. So the goal of using the OCPs and the HRTs is different. So OCPs are mainly used for contraceptive use, whereas HRTs are to maintain a physiological status in the postmenopausal female, especially related to bone mineral density.
Okay, that's fine. History of similar complaints of cancer-related deaths. Which complaints are you looking for?
Any previous history of jaundice previously in this patient, sir, or any cancer-related deaths in the family pertaining
What
to
cancers? What cancers?
sir, cancers of the hepatobiliary and pancreatic system, sir.
That's
Like
it. That's it. That's it.
It can also be, sir, cancers of the colon, sir, because a lot of cancers, such as HMPCC
Right.
or PAP,
And
and also IBD, also have an
IBD?
so inflammatory bowel disease, so which is also related to primary sclerosing cholangitis, which also is precancerous, sir. Has the risk of malignant transformation, sir.
So it's ovarian, uterine, breast, right? Colonic.
Yes, sir.
Next slide, please. Okay, okay, next slide. Yeah, so what's your provisional diagnosis now?
Based on the history, sir, my provisional diagnosis would be obstructive jaundice, probably due to malignant etiology, sir.
So it's said it's called surgical obstructive jaundice, SOJ,
Surgery.
right?
Yes, sir.
Yeah, right. Okay. Anything else? Anything else you would like to say, or just say that straight away it is a surgical obstructive? That way.
Since there is a history of pain associated with the jaundice, sir, I would also like to keep choledocholithiasis as a differential possibility in this patient, sir, even though her age and weight loss contradicted.
Okay.
Yeah, no, actually 2-3 suggestions from my side.
Yes, sir.
Please don't mention in your summary like 70-year-old and female. So as
Yes,
far
sir.
as possible, refrain from using such words. Just mention that a lady aged 70-year-old, 70 years, right?
Okay, sir.
And I think one question was raised to you: what is the importance of socioeconomic status? So
Yes, sir.
always remember that in these patients, lower socioeconomic status patients may be more prone to catch chronic, hepatitis viruses, right? Like B and C, right?
Yes, sir.
So in long run, these have the potential to develop
To
into
cause
hepatocellular
hepatocellular
carcinoma
carcinoma, sir.
and
Yes, sir.
CLD,
Yes,
right?
sir. Yes, sir.
So this is what you were probably trying to look for, some liver disease when
Yes, sir.
you mentioned, right?
Yes, sir.
Okay, proceed. And based on the summary of the history alone, you should be having some provisional diagnosis in your mind with maybe
Yes,
at
sir.
least 2 to 3 differential diagnoses here itself, right? Before
Yes,
you
sir.
jump onto examination.
Yes, sir.
So seeing all this, what is your impression? What this patient is suffering from?
So my impression is that this patient is most likely suffering from surgical obstructive jaundice, most likely due to malignant etiology like periampullary carcinoma.
So
It
what
can
are the points in history which are favoring a diagnosis of periampullary carcinoma?
So the points in history favoring my diagnosis are the old age, so 70 years old. Uh, there is progressive jaundice. There is with high colored urine, as well as one episode of melena that was there. The patient also has loss of appetite and unintended weight loss.
So if jaundice, which is just 2 weeks duration, can you comment upon that it's a progressively increasing jaundice?
No, sir.
Is this time
Ideally, sir, I would.
sufficient to make a comment on that?
No, sir. 2 weeks is not sufficient to make a comment on whether it is progressive or not, sir. But since there were no waxing and waning of the jaundice within the 2 weeks that she presented, um, I think that this is of malignant etiology, sir.
No, but you
What
mentioned
is,
that when patient had melena, episode of melena, after that patient was symptomatically better. This is what you mentioned.
Yes, sir.
So indirectly it is an indicator of waxing and waning,
Yes, sir.
right?
Yes, sir.
So you will like to
no, you
here
can't
put a
say
diagnosis.
both. Arnav, you can't say both. That there is no waxing and waning and this waxing and waning. You
Sir,
can't write both the books.
yes, sir. Sir, since the history of melena is just 1 day ago, the change in the improvement in symptoms are not that evident currently, sir. Uh,
Look, Arnav, they are not very important. Waxing and waning is not a very important. It's not very common, right? Which is the
yes, sir.
commonest periampullary carcinoma and which is the rarest?
So the commonest one is CA head of pancreas, sir, which is almost
Right.
70 to 80%, sir.
Right.
And
So you don't have
and the
waxing and waning
rarest
there. Yeah, rarest is
second CA in the duodenum, sir, in the second part of duodenum, which is around 5%, I think, sir.
ampullary carcinoma is one of the rarest.
Or ampullary, yes, sir.
So it's not very common. You
Yes,
can't
sir.
just base it on that
Yes,
waxing
sir.
and waning.
Yes, sir.
Jump on the examination, please.
Yes, sir.
Yeah.
On general examination, my patient is alert, conscious, and cooperative. She's well oriented to time, place, and person. She's of average build with a BMI of 21 kilograms per meter square. She's well hydrated. The atris is present over the upper bulbar sclera. There are no signs of pallor, clubbing, cyanosis, lymphadenopathy, or edema. There's no supraclavicular lymphadenopathy, no signs of petechiae or purpura. There are no signs of chronic liver disease. My patient is afebrile. Scratch marks are present over bilateral lower limbs and back. My patient's blood pressure is 120 by 80 millimeters of mercury, taking in sitting position on the right arm. Pulse rate is 84 per minute, fair in volume, regular in rhythm, no radioradial or radiofemoral delay or peripheral pulses are palpable. Respiratory rate is 14 per minute, thoracoabdominal in pattern. SpO2 is 100% in room air. Her ECOG score is 1. For abdominal examination or inspection, the abdomen is neither
Arnav,
scaphoid. Yes, sir.
how will you differentiate between the scratch marks that they are secondary to jaundice, or there may be some underlying or coexistent dermal, lesion or dermal pathology? Just
Sir,
on inspection, how will you, make your mind that this scratch marks may be because of the jaundice itself?
Sir, usually uh, scratch marks due to any dermal condition will also have other signs, sir, of the dermal condition. Suppose
Yes.
some lesions might be present, sir. There might be blisters also present along with the skin condition, sir. Also, due to obstructive jaundice, the scratch marks are usually present in the exposed area, sir. So that might be an indication that it is due to obstructive jaundice, sir.
So generally, the scratch marks, because of the jaundice, they are linear and they are thin. And when you examine them carefully, you will see that some blood ooze, some micro drops of blood you will find in them, right? Because invariably there is some degree of coagulopathy which exists when patient is having obstructive jaundice.
Yes, sir.
Please go ahead.
For abdominal examination, on inspection, the abdomen is neither scaphoid nor distended. The umbilicus is centrally placed and inverted. All quadrants moving equally with respiration. No scar, pigmentation, or venous prominences are present. No swellings are visible. No visible pulsations or peristalsis is found. Bilateral flanks are not full. Bilateral renal angles are not full. On palpation, temperature is not raised. No superficial or deep tenderness is present. The inferior border of liver is palpable 3 centimeters below the costal margin along the mid-clavicular line. It is non-tender. The inferior margin is regular with smooth surface. It is firm in consistency with no nodularity. 2 into 2 centimeters globular lump palpable in the right upper quadrant, lateral to the rectus border and inferior to the liver margin, which is non-tender and moves with respiration, and smooth surface and firm in consistency. The bilateral renal angles are non-tender. All hernial orifices are intact. On percussion, dull note over the liver and the gallbladder is present. The liver span is 16 centimeters in the mid-clavicular line. Tympanic note is heard over the rest of the abdomen. There is no evidence of free fluid in the abdomen. On auscultation, normal bowel sounds are heard over all quadrants of the abdomen. For vaginal examination, there is no abnormality which is found. For rectal examination, perineal skin is normal with normal inland tone, rectal mucosa, and the fingers is stained with clay clear stool. Other systemic examination. Examination of the respiratory system, CVS, CNS, and musculoskeletal system is normal. Summary. My patient is a 70 years old female, presented with complaints of pain in the right upper abdomen associated with progressive jaundice, itching over all her body, high colored urine, passage of clay colored stool with one episode of melena 1 day ago. Patient has history of loss of appetite and unintended weight loss with no history of prodromal symptoms. On examination, she is icteric and with hepatomegaly and pathogenic gallbladder. Hence, my provisional diagnosis is obstructive jaundice, most likely due to periampullary carcinoma.
Okay, let's go to your first slide of examination.
Now, why you have kept a diagnosis of differential diagnosis of choledochal cyst and choledocholithiasis?
So,
have you seen any patients of these two disease where patient has loss of appetite and weight loss?
No, so choledochal cyst and choledocholithiasis do not have any history of weight loss. Those are points in against for choledochal cyst and choledocholithiasis. However, since my patient has obstructive jaundice, which is still recent, and the jaundice was associated with the pain, which is why there are points favoring choledocholithiasis.
No, okay, hang on. How does a choledochal cyst usually present as?
The choledochal cyst will usually present with jaundice, sir, as well. There might be a lump also in the right upper quadrant of the abdomen.
No. Do they present with a lump and jaundice usually?
So they usually. So they usually present with a jaundice, sir, and a lump may be palpable.
Hang on. Usually they don't present with anything. It is just a finding on ultrasound or an MRI. They may have stones inside. They can present as choledocholithiasis, but per se, choledochal cysts don't have any symptoms unless they are very large. Right?
What's the usual age of the choledochal cyst? When do they present?
Usually in the younger females, sir.
Your patient is 70 plus, isn't it?
Yes, sir.
So I think choledochal cyst should not be a differential diagnosis here.
sir.
Okay, let's go to
Okay,
your
go
first
back
slide.
to your inspection of the abdomen.
Sir.
So Arnav, you have mentioned neither scaphoid nor distended. That means so negative things are coming in your picture, right? But you are not telling what actually it is. So you should actually tell what kind of abdomen patient is having, right? And all quadrants are moving equally with respiration. So it's not equal movement with respiration of all the quadrants, right? So the correct term here is all quadrants are moving proportionately with the respiration, right?
Yes, sir.
And what about venous prominence you want to say?
Sir, in cases of chronic liver disease, the
So
capillary medusa
is
may
it
be
a venous
found
prominence there or a dilated veins?
dilated veins, sir.
So there is a difference between venous prominence and dilated vein, right?
Yes, sir.
And you have not mentioned anything or any word about the spine, neither in the inspection nor in the palpation. Is
Sir,
it
about
important
the
or not?
sir, about, I'm sorry, sir, I couldn't. The connection was weak, sir. I couldn't
Spine,
hear.
spine.
Yes, sir. Sir, I've mentioned the examination of the musculoskeletal system was within normal limits. Within the examination of
No, in the
musculoskeletal
local
system, sir.
examination.
So I haven't mentioned, sir.
Okay, Arnav, let's go to
Any
your
other
first slide.
examiner wants to say something? Dr. Shashi, Dr. Pritesh?
Sir.
Arnav, let's go to your first slide of your examination. Okay. BMI is 21.
Yes, sir.
You think the patient would be with weight loss and all that kind of thing, have weight loss, BMI of 21, unless she was very obese, right?
Sir,
And well hydrated.
Yes, sir.
Usually, jaundice patients are not well hydrated.
Yes, sir. But in my patient, sir, she reported a history of significant weight loss by the fact that her clothes had become loose over the last month.
Okay,
And
okay, we'll accept that. Okay,
and
next slide.
Yes, sir.
We would like you to give us the vitals before you going for supraclav and petite and all that kind of thing.
Okay, sir.
Okay.
Yes,
Right.
sir.
Next slide. Your vitals say radiofemoral, all pulse peripheral. Is that what you do in a patient of jaundice? Is that important?
No, sir, it's not important, sir.
Then why go through all that? You're doing it's a postgrad exam, no? It's not an MBBS exam. And radiofem and all, you do it in your peripheral vascular disease. If there's anything, you never do it. Do you do it in your OPD, in your ward? Never do it.
Yes, sir.
Don't even think about it. Yeah, next slide. Okay, so you made the patient sit up after first you inspected the patient lying down, and then you made the patient sit up to look at the flanks.
Yes, sir.
Okay. So usually what we do is that you start from examining the patient in sitting position, and then make them lie down, right?
Yes, sir.
Okay, next slide. Oh, okay. Again, renal angle, hernia. Look, you can't examine the renal angle, then go back to the hernia, then go back up to the lump, all that kind. There should be a sequence. No? We know that you're doing it that way. Next slide. No, it's just go back. Is it moving with the respiration? What do you say? Okay. Next slide. Next. No other lymph nodes anywhere?
No other lymph nodes anywhere, sir.
Okay, next. Okay, that's fine. Okay. Anyone else, or should we go, sir?
Where did you look for the liver span in your patient?
Sir, on percussion, sir, on percussion on the right, when I was doing percussion of the chest, sir, I found I calculated the liver span, sir, based on the dullness.
Where?
So in the mid clavicular line, sir.
Hmm?
In the mid clavicular line, sir.
There's a gallbladder lump is there.
Yes, sir.
So there's a gallbladder lump is there.
Intercostal space.
What is the site of the gallbladder lump here? It's in the mid-clavicular line, isn't it?
Yes, yes, almost in the mid-clavicular line, just lateral to it, sir.
Probably you cannot measure the lever spine at that place. No? Either
Sir,
you have to go
a
medially
more
or
appropriate
laterally.
position would have been, sir, the anterior axillary line in that case, sir.
Mhm. And what is the purpose of doing the PR examination in this patient, to look for all these things?
So the parietal examination as well as the vaginal examination is to look for any mass in the pouch of Douglas, sir.
But that you are not mentioned anywhere in the TV also on the PR examination.
So I've mentioned that there was no abnormality found, sir. I haven't specifically mentioned that no nodes were no swelling was present in the pouch
So
of
the
Douglas.
examiner has to, put it, think what are the abnormalities, is it? You got to mention them, boy.
So
You got to mention them. You can't just say,
yes.
okay,
Dr. Arunav, I had 2 or 3 points for you. Like sir mentioned, examination sequence needs to be altered. First, when you see the patient, it's important that you assess the general condition of the patient given by the WHO performance score or the ECOG score. Then you check the vitals, and then you come to the pertinent findings regarding hydration status, pallor, ictus, and so on and so forth. As for abdominal examination, as an exam going MS or a DNB student, you are required to comment on external genitalia, which was not mentioned in your slide, both under inspection and palpation. Although it may not be directly related to a case of obstructive jaundice, but it's still, it needs to be mentioned. The other thing in abdominal examination, very important, is you never mention about presence or absence of splenomegaly. We have a list of differentials with obstructive jaundice that may have concomitant splenomegaly also. Although again, not entirely relevant in this case because the duration is very short, but you may get patients who have a longer history and more confusing diagnosis. So splenomegaly is an important finding
Yes.
that you could include in your examination.
Okay, sir.
yeah, why is splenomegaly important?
Sir, in patients with coexisting chronic liver disease, because of the portal hypertension, splenomegaly may be present, sir.
Right.
Dr. Shashi Prakash, you want to ask him any question till here?
Now, what is drop space? When we are discussing about the splenomegaly, what is drop space?
I'm not exact. I'm not. I don't remember, sir.
Yes, the space on the left side around the sixth rib anterior line. There's a splenomegaly is there.
Sir, yes, sir. Drop space, sir. It is usually a crescent-shaped area on the left lower anterior chest wall, sir. There's a resonant note on percussion in the drop space, sir.
What is the drop
So
sign?
if there is,
Any idea about what is drop sign?
Sir, the presence of the resonant note due to the gastric fundus being there is
Drop
the drop
sign
sign.
is different. And drop sign is totally different. Where you find in the patient the aortic regurgitation, you get the pistol shot at the femoral vessels. Okay, so it is drop space and drop sign, they are totally different.
So,
now, if you have to look for the prominent veins, in which
yes, sir.
part of the abdomen you will look for that?
So the central abdomen around the umbilicus, sir.
So you have to differentiate between whether it is because of the portal obstruction or because of the IVC obstruction. Where you will look for the prominent veins or dilated veins?
Sir, if in case of IVC obstruction, sir, the prominent veins would be in the lower abdomen and in the flanks, sir. Whereas in the portal obstruction, it is usually in the upper abdomen, sir. We can use a finger compression test, sir, to delineate what is the direction of flow in the vein, sir. And so based on that, we can also decide if it is due to portal obstruction or due to IVC obstruction, sir.
So you have to always examine below the umbilicus.
Yes, sir.
Then only there will be a reversal of the flow will be there in these two.
Yes, sir.
When you are demonstrating the flow of the vein, what is that sign called as?
So finger compression, milking of the veins is done, sir. I'm not sure about the name of the sign, sir.
That is the Harvey's sign.
Yes,
Okay, when you want to find the direction of the flow.
yes, sir.
Okay.
Okay, so how will you manage this case now?
Sir, after admission, sir, I would first assess the hydration status of this patient, sir. I would probably start the patient on vitamin K supplementation.
How do you assess hydration?
So by
The best way.
skin pinch, sir, and seeing how the skin relaxes after the pinch, sir, and also the using the after seeing the tongue, sir, whether it is wet or not, sir. If it is a dry tongue, the
Okay,
patient is likely to be dehydrated.
These are subjective. Any objective way of deciding hydration?
Sir, the urine output, sir. The measuring the urine output per hourly or on a 12-hour basis, we can assess the hydration.
Anything else? What about PCV?
Yes, sir. Both the hematocrit as well as the packed cell volume will be increased in a case of in a patient who is dehydrated.
If the hemoglobin is normal, if the total RBC number is normal, then
Yes,
PCV
sir.
is a good one.
Yes, sir.
Okay. So hydration, then what do you do?
I will start the patient on.
You do not want to make a diagnosis here. You are starting all the treatment for this patient.
Sir, I would do both together, sir.
Okay. So say
sir,
that. Yeah.
Yes, sir. So I will start the patient on vitamin K supplementation, sir, using in the intramuscular injection, sir.
Just make a diagnosis here.
Sir, for the diagnosis, sir, I would first perform an ultrasound whole abdomen, sir, to see if any mass lesion can be seen, sir. Ideally, to figure out the cause of the obstructive jaundice, we should do a MRCP scan, sir.
No, hang on.
On ultrasound, you will only see the mass lesion in the pancreas.
As well, we will also see the.
How do you say on ultrasound it is the obstructive jaundice or it is the medical jaundice?
So the presence of dilatation of the CBD at the porta, sir, as well as the presence of intrahepatic biliary radical dilatation, sir.
And what is the difference between obstructive jaundice and surgical jaundice?
Sir?
What is the difference between obstructive jaundice and surgical jaundice? Can a obstructive jaundice be medical jaundice?
I'm not sure, sir, if any obstructive jaundice can be.
What is the cholestatic phase of the hepatitis?
Sir, in hepatitis, because of the inflammation, there is also cholestasis that is involved, sir, within the biliary
tree. That is the obstructive jaundice, but it's the medical cause, no?
Yes, sir. Yes, sir.
Okay. So first you have to see on the ultrasound whether it is which type of the jaundice is there. Then what are the other findings you will get?
Sir, if there are any gallstones associated, sir, if the dilatation, the cystic duct diameter, sir, the dimensions of the CBD at the porta, sir, the presence
first
of
diagnosis in this patient is the periampullary carcinoma.
Yes, sir.
So keeping that in mind, what are the ultrasound findings?
So keeping that in mind, sir, we will see a dilated CBD with IHBRD. Plus, we may also see.
Hang on.
Yes, sir.
Arnav, just don't keep harping on dilated CBD. We've got that. You've said it numerous times. Tell us what are the important things which are going to look for in ultrasound in this case.
So mass lesion on the pancreas, sir. We will look at the
mass. We've got it. There could be mass. Okay, fine. The IHBR could be dilated. And what else? What if it is malignancy? What do you look for?
So any lymph nodes that are present as well, and the signs of metastasis, sir. On the liver, if there are any nodules present, sir.
Anything else?
What is double duct sign?
Double duct sign is a dilatation of both the pancreatic duct as well as the terminal CBD, sir. Usually due to a periampullary CA, sir.
Yeah, so that is probably one of the most important thing you're going to see on that. And that there will be Bile
double
duct will
duct
be
sign.
dilated till the lower end.
Yes, sir.
Plus also there will be dilated pancreatic duct will be there.
Yes, sir.
Okay.
You look for free fluid, right? You look for secondaries, you
Yes,
look
sir.
for splenomegaly all the time. Okay.
Yes,
Ultrasound, what else?
sir, I would do after I do the ultrasound, I will do a magnetic resonance cholangiopancreatography, sir.
No, hang on. You do an MRCP straight away. Is that the thing for the next investigation for periampullary?
Sir, in case of radiological examinations, I would do USG and then MRCP. Along with that, sir, I would also do
Hang
biology.
on, Arnav. I'll not really move forward. What does the NCCN guidelines say?
So we have to also do blood tests along with it, sir.
No. Have you gone to the NCCN guidelines? You've not.
No, sir.
Yeah, that's why. The next is CCT pancreatic protocol.
Sir.
MRCP does not help you here. Why do you want to get an MRCP? Will it show us the tumor?
No, sir.
Then
so I would do a CCT with contrast enhanced CT scan with the pancreatic protocol, sir.
now what is pancreatic protocol?
So the images are taken in 3 phases, sir. First a non-contrast phase is taken, then the arterial phase.
Okay, fine. Okay. Have you got the CT report here?
No, sir. The CT hasn't been done for this patient yet.
Okay. Next investigation.
Sir, I would do blood tests such as
any blood test, of course. What is important in blood tests here?
So liver function tests, sir.
That is routine. Tell me specifically for this patient.
So CA19-9 tumor markers, sir.
And
CA tumor markers as well, maybe
right.
raised.
You get both as well. No, you have to get both of them.
Yes, sir.
Okay. Next investigation.
So I would do an ERCP and a breast cytology, sir.
No. ERCP. If it is only in the ductal, only then you get a breast cytology.
Yes, yes. Sir.
You won't get it. CA head of pancreas is there. You won't get any fun in doing breast cytology.
Yes.
So
Sir.
what's the next investigation? Okay, let me tell you. Sir. I'll ask you a question. What is the role of colonoscopy here?
So to rule out any colonic polyps that may be associated, sir, because HNPP as well as Lynch syndrome as well as PAP syndrome are associated with.
Okay, fine. How will that help you in your diagnosis as periampullary?
So presence of these polyps have a higher risk of periampullary carcinoma, sir. So
is it carcinoma or is it adenoma?
It's
periampullary adenoma or periampullary carcinoma?
Periampullary adenoma, sir.
So actually, if you do a colonoscopy and you find a polyp there and it is malignant, chances of this one also being malignant is high. Even otherwise, if it's found, the chances of it there being an adenoma or malignancy is high.
Yes, sir.
Okay, next investigation.
Will you do upper GI endoscopy in this patient or not?
Sir, upper GI endoscopy, sir, yes, sir, I would do
I'm not saying a ERCP, upper GI endoscopy.
Yes, sir, upper GI endoscopy will be done, sir.
With
endoscopy ultrasound, sir.
With FNAC.
With FNAC, sir.
Now, why is this important?
Sir, because endoscopic using ultrasound guided endoscopy guided ultrasound, sir, we may be able to locate the lesion better, sir, and also comment on the nodal status, and we may take a targeted biopsy of the CA head of pancreas that might be present, sir.
Very good. So what is important in biopsy that you have to rule out? What is so important there?
Sir, in case if you're taking any lymph node biopsy, sir.
No, not lymph node. I'm talking of the biopsy of the lesion. Look, there are two types. There's intestinal type and there is ductal type, right?
Yes, sir.
So if it is ductal type, the prognosis is much worse than intestinal type. Also, it could just be an adenoma, right?
Yes, sir. Yes, sir.
A papillary ampullary adenoma, which can cause all these kind of findings,
Yes, sir.
right? So don't assume that it's malignant. At this stage, of course, we would, but then there is a possibility of this. So that's
Yes,
why
sir.
you have to do this,
Yes, sir.
right? Now what?
Sir, after
Now,
once we've gotten a diagnosis of CA head of pancreas or with the with pancreatic protocol, and if the disease is resectable, then we would go for operative management, sir.
okay, what do you mean by
After
resectable?
stabilization of the patient, sir.
Any other investigations would you like to do?
So apart from routine investigation,
No. Routine, so you'll do here. That even if the appendicitis, you'll do routine investigations. We're not interested in that. Any other important investigations would like to do? How do you decide for resectability?
so we have to look for vascular encasement of the vessel, sir.
That you'll get in your
in a
in
in
your
a CT.
in a PET CT.
Yes,
In your
sir.
CT. You have to
In
get
my,
a PET CT done. Any role of PET CT?
sir, to see if there is if this disease is metastatic, sir, we have to do a PET CT, sir.
Okay.
And, and if
What
there are
about
tumor
laparoscopy?
sir,
What about laparoscopy?
a
What
diagnostic
about laparoscopy?
laparoscopy, a diagnostic laparoscopy has to be done, sir, before the operation, sir, to check for peritoneal metastasis, sir.
Okay. So let me come to some basics. How can you clinically decide which component of periampullary carcinoma this is?
Sir, if there is a history of vaccine and waning as well as melena, it points towards CA, the ampulla of Peter, sir.
Is
If
that
there
it?
is,
Is that it? Melina seen only in CA ampulla fetor.
so it goes more in favor of the diagnosis of ampulla
What are the
Peter, sir.
components of CA periampullary carcinoma?
So CA head of pancreas, CA distal cholangiocarcinoma, sir, CA ampulla of Peter, and CA head of pancreas, sir.
Okay, not CA duodenum.
CA second part of duodenum, sir.
So you can get melina if the CA head of pancreas infiltrates the duodenum. You can get
Sir,
melina
we can
if there is CA
features of
duodenum.
gastric outlet obstruction as well, sir, and
Right.
duodenal
No,
outlet.
look, my question is for melina.
Sir.
We'll come to gastric outlet obstruction later on.
Yes, sir.
So these are the frequent causes of melina.
Yes, sir.
Right. Now let's come to gastric outlet obstruction.
So
What are the ones?
if patient has a CA second part of duodenum, sir, the patient will have recurrent vomiting, recurrent vomiting
Okay,
along
gastric
with
outlet obstruction is seen most common in which type? Which component?
second part of duodenum, sir.
Is it?
When
Not CA head of pancreas. It's CA head of pancreas, which generally leads to gastric outlet obstruction. CA duodenum is not an infiltrate. It's not it's a infiltrative type.
Sir.
Right. It's an ulcerative type.
Do you get the gastric outlet obstruction in periampullary carcinoma?
Sir, very unlikely, sir. Very rarely.
Once you say it's the carcinoma head of the pancreas is there, then it has to be a huge tumor to cause the gastric outlet obstruction.
Yes, sir.
Much more than 2 centimeters.
Okay. Now, suppose the lump is palpable. You have
Yes,
a
sir.
palpable lump.
Yes, sir.
Right? Not gallbladder, just a lump in the epigastrium. What
Yes,
kind of periampulary can you rule out?
if it is a palpable lump, sir, it is most likely not a CA ampulla of Vater, sir. It will be either distal CA.
No,
It will
distal
distal
carcinomas also
cholangiocarcinoma, sir.
don't present with lumps.
Yes, sir.
CA head of pancreas is the one which presents with lumps. Right? Okay. So anyone?
So how you are going to have you done the LFT in this patient?
Yes, I've done the LFT in this patient.
Can you just show that?
So in the
No,
LFT, the total.
CA 99 raised. What do you mean by raised?
So CA 99 in this patient was 132 international units per ml, sir.
So write that. Yeah, raised means what? It could be just 20, so 24, 25.
So
Yeah. Answer sir's question. Professor Khanna's question.
Okay. So how you are going to, have you done the CCT in this patient? No, it has not been
no,
done.
sir, not been done yet. Sir.
Okay. So if you think it is a resectable tumor and you are planning for the curative surgery,
Yes, sir.
how you are going to prepare your patient with a bilirubin of 12 milligram per deciliter?
Yes, sir. Sir, I will start the patient on injection vitamin K intramuscularly, sir. I will optimize the patient's hemoglobin as well
Which
as the
vitamin K
PTNR
you
status.
give? Which vitamin K you are giving? Which vitamin K you are giving? What is not there in this LFT? If you are telling about the vitamin K, what is there in not in this LFT?
So the PTNR level has not been mentioned, sir.
Yeah, so that you should show, you should tell
Yes, sir.
about that, yeah.
Yes, sir.
So it is the
Why
method need.
PTINR is important?
So because of the it tells us about the coagulation profile of the patient, sir.
Okay.
So will the
And
So you give vitamin K.
become normal after giving the vitamin K?
So it will become normal, sir, after adequate supplementation, sir.
It will never become normal,
So,
it will decrease, but never become normal, even after you have given the patient the vitamin K.
yes, sir.
Usually
So
for how
just
many days you give it?
So usually vitamin K1 is given, sir, usually for at least 1 week, sir, to optimize the patient's PTNR, sir. But it depends
Okay,
on.
what is vitamin K1 called? What you said, vitamin K1. What is it called?
Yes, sir. So it is called as phytomenadione or phylloquine, sir.
Right. Vitamin. Okay.
Sir.
So what does vitamin K do?
Sir, it helps in absorption of vitamins such as vitamin A. It helps in the synthesis of coagulation profiles, sir. Synthesis of coagulation factors in the liver, sir, because vitamin K is deficient in obstructive jaundice because it is a fat soluble vitamin, sir, and it is not absorbed due to obstructive jaundice, sir.
No, so you're giving vitamin K now. Why does it need vitamin K?
So because
How
vitamin
is vitamin K related to coagulation factors?
Synthesis of coagulation factors, sir, occurs in the liver, sir, and it is dependent on vitamin K for its synthesis.
Which are vitamin K dependent coagulation factors? Let's come to that.
Factors 2, 7, 9, and 10, sir.
Right. Okay.
So what are the various fat soluble vitamins?
So vitamins A, D, E, and K, sir.
Okay. So can it precipitate in if there is vitamin A deficiencies is there? How the patient will present?
The patient will have, sir, dry cornea, sir. He will have itching of the eyes, sir, and patient will also, in extreme cases, sir, patient may also have night blindness, sir.
Night blindness may be a feature of that, yeah. Okay.
Dr. Aruna, what is the importance of SGOT and SGPT in a patient with obstructive jaundice, especially in the preoperative period?
So the SGOT and SGPT tells us about the hepatocellular activity of the patient, sir. If there is if the SGOT and the SGPT are raised, sir, it indicates hepatocellular damage, sir, and so we have to optimize the patient accordingly. Which means that the patient is if it is raised, sir, it means that the patient is slowly going towards biliary cirrhosis.
cirrhosis is a much advanced
Advanced
scenario.
stage, sir,
And
but
we usually do not see it in malignant cases.
Yes,
Biliary
sir.
cirrhosis sets up in long-standing benign obstruction. By the time malignancy is advanced, I think patient will succumb to their malignancy rather than biliary cirrhosis. The other
Yes.
thing is, if SGOT and SGPT are raised in the preoperative period, it may suggest subclinical cholangitis. So you have to treat that first, otherwise your surgical outcomes will be really bad.
Yes, sir.
Also brings me to the next question. What is your understanding regarding the role of preoperative ERCP stenting at a bilirubin of 12 in this patient? Would you consider stenting or not?
I would consider stenting, sir, in this patient, sir, because ERCP will not only not only give me an opportunity to normalize the bilirubin level, sir. It will also allow me to get a brush biopsy from the periampullary location, sir, and also tell me about the anatomy of the biliary tract, sir. So
No, why do you want? No, hang on, Arnav. If the patient is operable, right?
Yes, sir.
Do you need a stenting? You need stenting.
Preoperatively, if the bilirubin is raised, sir.
Even if raised, even if you think by stenting the bilirubin level will come down to less than 2, and then you can operate.
I know, so it will not become less than 2, sir, but it will reduce slightly, and it will be easier to.
Okay, tell me the indications for
for
stenting now. Tell me the indications for stenting.
Sir, in case if there's cholangitis and biliary stasis, we and there's an indication for stenting, sir. If there is
No. Hang on. All Arnav. Cholangitis and biliary stasis there everywhere. It'll be there in all cases, all obstructive jaundice. So all cases you'll do stenting.
No, sir.
When you're going to go in for surgery,
yes,
there's
sir.
no rule of stenting as such. You go and
Yes, sir.
straight away operate. Bilirubin
Yes, sir.
level does not matter unless your anesthetist is having wet feet, right? Stenting is done when you can't operate straight away.
Yes, sir.
When the patient's nutrition is very poor, when the coagulation is very poor, when there's infection, right?
Yes, sir.
So then you do a stenting and you build the patient up. Or the patient is inoperable, then you stent and give any adjuvant treatment.
Yes, sir.
Okay.
Yes, sir.
Are you aware of any risk of stenting, ERCP stenting, complications of ERCP stenting, particularly in your case?
Sir, it may lead to pancreatitis. Bleeding is an immediate complication, sir. It may also lead to pancreatitis.
Yes.
Yeah, so very high risk.
Right. So you stent before that, and the patient gets pancreatitis or starts bleeding, and you can't operate the patient then.
Yes, sir.
Right. So it is only done. It's not routinely done.
Yes, sir.
Right.
You have mentioned that albumin is decreased. So do you think that there is any significance of low albumin level, or albumin level?
Sir, yes, sir. It indicates the activity of the liver cells, sir. So if the albumin is decreased, it tells about the total nutritional status of the patient, and so we have to optimize the patient before undertaking a major surgery, sir.
Okay. Yeah. What does the level if the albumin is less than 2? What does it tell you? What red flag does it raise?
It tells me that the patient's protein status and the nutritional
That we
status.
know.
Yes, sir.
It is a red flag that the outcome will be very poor.
Outcome will be poor, sir.
Most
and there is
patients
high
with
chances of
less than
bleed, sir.
2 will have a poor chance for survival.
Yeah,
Yes,
it will be a very poor
in
outcome.
any case, in any case, it may be perforation, it may be any other case. If the albumin is less than 2, the chance of outcome is poor.
Yes, sir.
Now, suppose your laboratory investigations of CA19-9 showing very high level, like more than 1,000.
Yes, sir.
Will you explain anything to the patient, or will it indicate anything about the prognosis?
So if the CA99 is raised above a level of 1,000, sir, it usually indicates metastatic disease. And so we have to explain the patient to the patient that this indicates that the cancer is most probably non-operable, and so they have to consider.
No. Hang on, Arnav. It
So-
doesn't indicate metastasis, please. What does it indicate?
Malignancy, sir.
It indicates that it is aggressive form. The grade, it is of a high grade tumor.
So
Biologically aggressive tumor, yeah.
It doesn't, not metastasis. What tells you about metastasis? What test will tell you about metastasis?
So the PET scan will tell us about the presence of metastatic.
So you got to get a CT
lesions,
chest
sir.
and a CT pelvis and abdomen done,
Yes,
and
sir.
alkaline phosphatase.
And alkaline phosphatase, sir.
Yeah,
Which-
all those tells you.
Yes, sir.
Not CA or CA9. Okay. So now suppose the patient, you've done everything and
Yes,
you
sir.
take the patient up for surgery, right? So what surgery will you do for this patient?
So I would do modified Whipple's for this patient, sir. If the patient patient is has a resectable disease, I would go for modified Whipple's surgery, sir.
Arnav, what is modified Whipple's?
Sir, it is also known as pylorus preserving pancreaticoduodenectomy, sir. In which the pancreatic head, the pylorus is preserved, the pancreatic head, the duodenum, the distal part of the CBD, and the proximal part of the jejunum is removed, sir, and then a reanastomosis is done, sir.
And what do you do with the gallbladder?
So the gallbladder is spared, sir.
Is it spared?
Sorry, sir, it is removed, sir. In the modified Whipple's, it is removed, sir.
So in Whipple's
No.
it's spared. Modified, it is removed, and
Yes, sir.
in Whipple's it's spared.
No, sir. In both classical Whipple's as well as modified Whipple's, it is removed, sir.
फिर बोलने का क्या मतलब spared, not don't bring in things. Just say gallbladder is gone.
So
Right?
And a few comments.
Yes, sir.
Actually, since the starting, you are giving a hint that you know the diagnosis. Since the starting, you are trying to take us to a HPV related pathology, right? Which should not be the case, right? Because she is a elderly lady who knows it's a primary ovarian malignancy with a large metastatic lymph node sitting over the porta hepatis and leading to jaundice. It may be a case, right?
So,
And you may see such cases not very infrequently, right? And other causes can be there. It may be a gastroduodenal malignancy or any other thing, right?
Yes, sir.
So since the start, you were on HPV pathology itself, right? So which should not be the case, right? Diagnosis,
Yes,
please
sir.
make always by exclusions, right?
Yes, sir.
And there was a question about the PET CT scan, right?
Yes, sir.
So PET CT scan in CA head of the pancreas in the diagnostic workup has only 2-3 indications, right? Generally, you don't recommend PET CT scan for your patients preoperatively, right?
Yes, sir.
So,
So only if there's
thorax,
suspicion of distant metastasis, sir, and if there's
so if
recurrence
distant metastasis, you are nicely seeing on CCT thorax or CCT whole abdomen, right?
Yes, sir. Yes,
So
sir.
it can help you in taking biopsies from those sites, and subsequently your patient can go for palliative or salvage whatever chemotherapy you advise, right?
Yes,
On
sir.
your adjuvant chemotherapy. And then there was a question about the diagnostic laparoscopy in CA head of the pancreas, right?
Yes, sir.
So again, in each and every patient of CA head of the pancreas, diagnostic laparoscopy is not a recommended tool, right? You do it only when there is a doubt either in the diagnosis or when there is a delay in the treatment, meaning that you have done all the imaging and all the investigations, say around 2 weeks or 3 weeks ago, and later on patient is being taken for OR. And in the meantime, you suspect that probably in my patient, disease must have been upstaged, right? Which is evident by either rise in bilirubin levels, rise in CA19 line levels, right? Or patient may have developed some de novo other symptoms, like patient may have developed free fluid in the abdomen, right? So in
Yes, sir.
past, free fluid ascites was considered as a strict contraindication for surgery. Nowadays, it is a relative contraindication. In fact, now some authorities say it is no more a contraindication for surgery or major resection, right?
Sir.
So you should have some kind of a system and coordination in your history presentation, right? Many things were in your examination were going haywire, right? Which should not be a case.
Yes, sir.
Right?
Yes, sir.
Otherwise, overall, your performance was good, right?
Yes,
Okay,
sir.
Arnav, I'll just ask you one question.
Yes, sir.
How do you relieve itching?
Sir?
How do you relieve itching?
So sorry, sir.
Symptomatic treatment for itching.
Sir, we can give antihistaminics, sir, as well as moisturizers to the patient, sir.
Okay, that's fine. Any specific drugs?
Antihistaminics, sir, like fexofenadine, sir.
Anything more important? Ursodeoxycholic acid?
Yes, sir. Sorry, sir. Deoxycholic acid can be given, sir.
Then, suppose that doesn't relieve, then?
I'm not sure, sir.
Cholestyramine?
Sir.
Right? Still not rifampicin?
Yes,
Still
sir.
not naloxone. Okay?
Sir.
And finally, of course, biliary drainage or anticonvulsants can also be given.
Sir.
Right. Dr. Karangal?
Yes, sir. Any doubts, Dr. You can share your presentation. And we have Dr. Sheil sir also joined in. Professor Sheil, do you have any questions to quickly closing comments? Fine. To clarify with the faculty.
Arnav, you want to ask any question?
No, sir.
Hello, sir. I'm okay. Is Professor Sinha joined Dr. Arnav?
Sir, I'm just going through the participant list, sir. I'm not sure if he has joined the Zoom meeting. I think he might be.
No problem. You please share this number to me. I do appreciate. Thanks. Thank you very much.
Thank you, sir.
Thank you all.
Arnav, I think you've done well. Right.
Yes, sir.
You've done
Thank you, sir.
very well. Good work.
Thank you, sir.
So you can stay for the second case discussion. Now, with the permission of the faculty, we move on to the second case. Dr. Tamar Mori, she is a postgraduate resident from Madurai Medical College, kindly contributed by Professor Saravanan sir. Can you switch on your PowerPoint and start your presentation, Doctor?
Yes, sir.
Make it full screen. Yeah.
Yes, sir.
Good luck, Dr.
Yes, sir. Thank you, sir. Good evening, all professors. And I thank my HOD, sir, Dr. Saravanan, sir, for giving me this opportunity to present in this PG clinics, and Dr. Kanagavel, sir, for guiding me in this presentation. Thank you, sir. Today's my topic is carcinoma lip. I'm a postgraduate, second year postgraduate from Madurai Medical College. I'd like to present a case of a 60 years female. She's a resident of Dindukal, farmer by occupation and of low socioeconomic status. She presented the chief complaints of growth in the lower lip for 10 months. This is a clinical picture of the growth. History of presenting illness. The patient was apparently normal 10 months back, after which she developed a small blister which evolved into a growth near the left side angle of the mouth. which gradually progressed to attain the current size. History of pain in the growth for the past 6 months. Pricking type, intermittent in nature and non-radiating. No aggravating or relieving factors. History of foul-smelling breath. Halitosis present. No history. History of difficulty in opening the mouth for the past 1 month. History of prolonged exposure to sunlight, as she's a farmer by occupation. That's more than 6 hours. History of occasional bleeding from the growth. No history of excessive salivation. No history of difficulty in chewing or swallowing. No history of difficulty in speech or protrusion of tongue. No history of hoarseness of voice. No history of loss of appetite or weight. No history of chest pain, breathlessness, or hemoptysis. Past history, no history of similar illness in the past with no known comorbidities. No history of previous surgeries. No history of previous irradiation to the neck. No history of the patient gives a history of incision biopsy done after admission. Personal history, she consumes a mixed diet. She has a normal sleep pattern, normal bowel and bladder habits. History of betel leaf chewing since the age of 10 years, and a history of tobacco chewing, that's quid, since the age of 15 years. And she has a habit of keeping the tobacco quid in the anterior and left gingivobuccal sulcus, even sometimes throughout the night. Menstrual history, menopause at 40 years of age. Marital history, she's married at the age of 15 years with a non-consanguineous marriage. Obstetric history, P5L4. All 4 children are alive now and one has died at the age of 3 months. Sterilization not done. Family history, no other thyroid or oropharyngeal malignancies in the family members. Summary, a 60-year-old female, farmer by occupation, with ulceroproliferative lesion in the left side angle of lower lip and angle of the lip, and lateral upper lip lateral border with pain and difficulty in opening of the mouth at the inlet, with halitosis and risk factors of tobacco quid chewing and chronic sun exposure.
Tamil, wait for the faculty to ask questions. You can go to the first slide by the time.
Yes,
Kanna
sir.
sir and Rajesh Sakai sir. Amit sir, would you like to ask questions on CLE as well? I'm not sure if you are interested on that.
Sir, actually, I think I have to leave because my net is getting very unstable. There is
Yes, sir.
some
I got it, sir.
thunderstorm and heavy rainfall which is started, so net is becoming very unstable, sir. Sorry,
Perfectly
my
understandable, sir.
apologies, sir.
Thank you very much, sir. Thank you.
Tamil, what is the
Sakai, sir.
angle of the lip?
Kanna sir, sorry, sir. Please, sir.
What is the angle of the lip you said?
Sir, the patient has a growth involving the left angle of the mouth and the lower lip and upper border of
Angle of the mouth
upper lip,
is there,
lateral
not
border.
the angle of the lip. Angle of the mouth.
Yes, sir.
Okay, not the angle of
Yes,
the lip.
sir. Okay, sir.
What do you understand by Indian cancer?
Sir, countryman's cancer is mostly that occurs in the farmers due to chronic sun exposure.
Indian cancer.
They develop ulcers in the lower lip.
Like your patient is typical of that, though it is involving the lower lip, but putting a
Yes.
quid in
Yes,
the
sir.
sulcus.
Yes,
That
sir.
is the history in your patient is there.
Yes,
And
sir.
that leads to that there is cancer in that sulcus which is there. That is
Yes,
the
sir.
classical Indian cancer which is there.
Okay, okay, sir.
Can you go to the next slide?
Yes.
Next slide here. Why he's having the pain in the growth?
Sir, due to the nerve involvement, and the pain may have progressed for the past 6 months. Sir.
Which nerve involvement will be here in this
Sir,
patient?
the sensory innervation for the lip is by the mandibular fifth cranial nerve. The lower lip is innervated by the mandibular branch of the fifth nerve.
So do you think it is because of nerve involvement here or it is because of infection?
For this patient, it might be due to secondary infections.
Why
How will you
this
distinguish between an involvement of pain because of nerve or pain because of infection?
There may be any referred pain.
Right, radiation.
Referred pain.
Radiation. Right?
Okay.
Will
Sir.
radiate along the nerve.
Okay.
But if it is localized,
Yes, sir.
then it is because of infection. Right.
Yes.
Okay. Do you think what is the difference between carcinoma involving the lip, the vermilion border, and an oral cavity carcinoma? You think this is a carcinoma lip going inside, or it's a carcinoma oral cavity moving outside? And what is the difference between the two?
Sir, this is a case of carcinoma lip because the lesion initially started in the outer aspect of the lip only, sir.
So you think the
There
lip
is
will
no
go
other
inside?
symptoms.
No. You think so? Now that tobacco has got nothing to do with it. It is because of the sunlight.
No, sir. Tobacco has only caused the tobacco and chronic sun exposure only has caused
No, they're two
the.
different. Dr. Tamil, they're two different.
Yes, sir.
Lip vermilion cancer, the commonest cause is sun exposure.
Sun exposure.
Oral cavity, the commonest cause is
Tobacco chewing. Yes.
So you can't label this. Okay, what is the difference between a lip cancer and oral cancer? Basic difference. What is the basic difference? Why do we not include lip cancer into oral cancers? Why are they treated differently?
Lip cancers, it will not involve the mucosa of the oral cavity.
No. Look, first of all, cancers of the lip has a different etiology. It can be smoking if you keep the cigarette around here, but it's generally because of exposure to sunlight. Also, most important is that the mucosa or the epithelium over the lip is very thin. You have keratinized and non-keratinized mucosa in the oral cavity. You know? Which are the
Yes, sir.
keratinized portions of the oral cavity?
Keratinized portion.
Yeah.
Lip vermilion
In the
body.
oral cavity. In the oral cavity.
Oral cavity.
So
Tongue,
areas such as the hard palate, the dorsum of the
hard
tongue,
palate.
all these are
Hard
keratinized
palate,
areas, right?
gingiva.
The floor
Yes,
of the
sir.
mouth, they are non-keratinized. Similarly here,
Yes.
even it is non-keratinized and very thin. So there's very early involvement of the neurovascular bundle. It's very richly supplied by blood vessels. So CA lip has a poorer prognosis.
Okay.
It shows up early. Patients come seeking help early because it looks bad. Oral cavity stays inside this for a long time till it comes out. Okay. Right.
Okay. Yes, sir.
What about halitosis? Why is there halitosis?
That is due to secondary, poor oral hygiene. They have a foul smelling lip.
Okay. One. What else? What else? Any other cause? Oral hygiene. Most people have lower class can have oral hygiene. They can. What is so important for halitosis here?
Due to the tobacco usage, they During the chewing, nitrosamines
She's
will
not chewing.
be.
She must not be chewing tobacco now.
Yes.
Look, what happens to a malignant? It ulcerates. It
Malignant
breaks down. There's necrosis.
polyamine.
There is necrosis, right?
Yes.
So that's why there is halitosis. This halitosis is very different from poor oral hygiene, right?
Yes, sir. Yes, sir.
Why this
Difficulty in
difficulty in mouth opening?
Sir, that is due to that lateral border and angle of mouth involvement. When she opens her mouth fully, she has bleeding sometimes. So she complains. She told the complaints like that, sir. But there's no trismus of the mouth, sir.
But what do you understand by difficulty in opening mouth? When do you say it is a difficulty in opening mouth? What is trismus?
When it is trismus only, we used to say difficulty in mouth opening. When there is trismus, we'll say there is difficulty in opening mouth, sir.
But when do you label that as the patient is having the trismus?
Sir, when we are not able to visualize the soft palate, we'll say it as a difficulty in opening mouth, and there are gradings of seeing the mouth opening.
So what is grade 4?
How many fingers will go in that?
3 fingers, normally 3 fingers, sir, and 4 gradings are there, sir.
Right.
Grade 1,
It's okay. That's fine. That's fine.
If a patient has the oral cancer and the patient
Yes,
has
sir.
got the trismus.
Yes, sir. No, sir, this patient is not having trismus.
Any pre-malignant condition which can lead to the trismus?
Submucosal fibrosis or
Submucous fibrosis is the most important one. Yes.
yes.
So how will you know the patient is having submucous fibrosis?
So we have to look into the oral, I mean, buccal mucosa for any
And what will you
submucosal
see?
fibrosis.
What will you see?
Sir, there will be mottling appearance in the buccal mucosa.
No, there's
Whitish
no
gray
modeling.
spaces.
Yeah, it's whitish.
Whitish
And
gray spaces.
there'll be fibers. You can see submucous fibers, right? Stretching around.
Fiber
That is
strands.
submucous fibrosis.
Fibrous strands will be present interspersed
Right.
between the white spaces. Yes.
Right.
Yes, sir.
So what's the treatment for that?
Yes, sir. Sir, there is we can locally excise the submucosal patch and we can repair it with the mucosa.
Is that
But that's very difficult and CO2 ablation can be done, sir. But doing all those things,
No, it's conservative management. You ask the patient to stop all that offending stuff. Give him vitamin K, vitamin C, right? B complex, all that kind of stuff. Okay, next slide, please.
multivitamins.
No history of excessive salivation.
Yes,
Why?
sir.
Why do you think? Why is there no excessive? Why is she not having excessive salivation? Because your next line says that there's no difficulty in swallowing. So even if there's excessive salivation, she's swallowing.
Yes, sir.
You get it? Had there been difficulty in swallowing, then it would have pooled around.
Yes,
no
sir.
history in difficulty in speech. What does that tell you?
There is a
that the growth is not involving the
muscular fibers.
The tongue. It's not involving the tongue. So difficulty in speech, swallowing, and protrusion of tongue, that shows that it's just confined to the gingival labial or gingivobuccal recess?
Yes, sir.
Next slide, please. Okay, don't make it past history, diabetes, mellitus. It is medical history, right? Previous
Yes,
surgeries,
sir.
previous radiation.
Yes, sir. Okay, sir.
There's no history of tooth extraction at this age. What's the age? 60.
60
All
years
teeth intact.
remaining.
All teeth
Yes, sir,
intact.
but it's all eroded, sir, but she has all teeth, sir. Every tooth is eroded. Tooth gapping is present, but there's no falling of loosening of teeth, sir.
So why is this what? Suppose there was spontaneous loosening of the teeth. What would that have told you?
It has involved the inferior alveolar margin, ridges, and bone involvement might be present. We can
So you can say that it
assess.
could be involving the bone. And tooth extraction. What is what tooth extraction everyone has? What is that particular thing about tooth extraction which raises a red flag?
Sharp bony, I mean, sharp tooth, chronic irritation of the mucosa and
No,
leading
tooth
to
extraction.
oral cavity.
After extraction, the socket refuses to heal.
Yes,
Is
sir.
one of the signs of malignancy, intrinsic malignancy. Okay.
Okay, sir.
Incision biopsy done on
Yes, sir.
okay. Okay, next slide, please. Okay, beetle leaf showing. How does beetle and tobacco, how do they affect, how do they cause, how are they cancerous? What is the thing in that beetle and
Sir, beetle leaf per se doesn't cause carcinoma, sir. The contents they keep inside the beetle leaf, that is the areca nut, slack lime, those are the chronic irritants that that are carcinogenic, and chronic irritation they cause dysplastic changes in the oral mucosa, leading to formation of malignancies.
okay. Okay, next slide, please.
Yes.
That's fine. Okay, next slide. Thyroid, oral, is oral cavity related, malignancies related to families?
Um, it's rare only, sir, but few malignancies can predispose to oral malignancies, like in Fanconi's anemia. There is a hereditary relation with oral malignancies, and some and other hereditary conditions like dyskeratogenesis congenita also, they are prone for oral pre-malignant lesions leading to
Scleroderma,
oral malignancies.
scleroderma, Fanconi's anemia, right?
Scleroderma, yes.
Ataxia
Yes. Yes,
telangiectasia.
sir.
These are the ones. Okay,
Yes.
next slide. Look, in history, you can't don't say ulcero-proliferative. This is the examination finding.
Oh, okay, sir.
Okay.
Yes. Okay, sir.
What is the human papilloma virus related to that?
Sorry, sir. Sorry, sir.
Human papilloma virus or
Yes,
the
sir.
oral cancers. How
Sir,
they are different
16
from the
and
non?
18.
Yeah.
16 and 18.
Yes. But what are the presentation of that? If the patient has got the HPV virus, do you get the cancer of the lip in HPV?
Oral malignancies, they are quite common, sir.
Which oral malignancy?
Papilloma,
Or alveolus?
tongue, base of the tongue, they are
Base of-
quite common.
Posterior part of the oral cavity, no? So
Yes,
base
sir.
Base of tongue, tonsils.
oropharyngeal is there.
Yes, sir.
That is for the HPV. And what are the other differences, basic differences between the HPV and the non-HPV?
HPV virus
You get the big lymph nodes in HPV. No?
okay, sir.
So it is in the posterior
Also,
part. It is the big lymph nodes which are there. Prognosis wise, is it better or it is?
Prognosis HPV positive malignancies, their prognosis is better, sir.
Is it better? Yeah. Okay. Though it is the advanced stage, but it is still better than that. Yeah.
Yes, sir.
okay, there are a few other differences, right?
Yes, sir.
Stage-wise, stage 2 stage better prognosis, but they are poorly differentiated. And the tumor is generally exophytic strawberry kind of thing, right? With multiple metastatic cystic changes and metastatic lymph. These are the differences. Okay, next
Yes,
slide,
sir.
please.
What is field cancerization?
Sir, field cancerization is if a malignancy is present in a particular place around the region, also there might be pre-malignant predisposition to malignancy, but they'll look normal on appearance, but they might be genetically predisposed. There might be predisposition for malignancy, sir.
So if a
Why does
patient
this happen?
has multiple cancers, okay, you think of the etiology that it is because of field cancerization. Another patient may have one cancer in the oral cavity, another in the pharynx, another in the esophagus. So that may be because
Yes,
of field cancerization.
Why does it happen
Yes.
in oral cavity? You don't get field cancerization in, say, in skin or in multiple. We don't get it here. Why? Why do you get field
Sir,
cancerization here?
they are close proximity of all the regions of the mouth in contact, and lymphatic spread is
No,
of
no,
the oral
no.
malignancies.
The whole oral cavity is bathed by saliva. So if there are any offending stimulants, it'll affect the whole of the oral cavity. So at some place it is
Yes.
more prone and it shows up. Other place it is just it's dormant and can come up later on. Right?
Okay. Okay, sir.
So what are the various pre-malignant conditions for the oral cancers?
Leukoplakia, erythroplakia, submucosal fibrosis, leukoerythroplakia, and the 6 years is spice, smoking, alcohol. Sorry, pre-malignant conditions. Sorry. Yeah. Lichen planus,
Okay.
chronic hyperplastic candidiasis.
Okay, done.
Yes, sir.
Yeah. No, tell us your biohistory. What do you think it is?
Sir, it might be uh, ulcer proliferative growth of the lower lip, mostly due to
It is malignancy until proved otherwise. Age, smoking, chewing tobacco, sun exposure, all these things there, right? Also proliferative
yes,
growth.
sir.
So you don't just spell it out, right? Okay.
Pharmaceuticals.
If you think in the
Anything
malignancy,
else?
what are the various types of cancers which can occur in the lip?
Sir, basal cell carcinomas can also occur. That is on the upper half of the face. So if it is involving mostly in the upper lip or in the upper part of the face, it can be due to basal cell carcinoma.
What is that line called? What is that line called? in the face where basal cell carcinoma occurs?
Holmgren's line.
And that runs from where to where?
The angle of lip to the ear lobules. Sorry, angle of mouth to ear lobules.
Why is that?
That is sun exposure
Very good.
mostly falls
That's
in
right.
the upper part of
Yeah, good, very good.
Yes.
Okay. So examination, sir, Professor Khanna.
Yeah, go on the examination here.
Yes, sir. General examination, pulse rate 84 beats per minute, regular in rhythm and normal volume. BP 120/70 in right arm sitting posture. SpO2 98% in room air. Conscious oriented afebrile, hydration fair. No pallor, icterus, clubbing cyanosis or pedal edema or generalized lymphadenopathy. Examination of the oral cavity. Inspection, an ulcero-proliferative growth of size 4 cross 2 centimeter in the left side of lower lip involving the angle of mouth, uh, uh, lower lip and lateral border of the upper lip involving the vermilion border, irregular in shape, well-defined borders and everted edges, irregular surface with no pus discharge or serous discharge, mouth opening decreased at the inlet, right commissure free, nicotine pigmentation of the patch, gums normal, poor oral hygiene present, dentition normal, bilateral gingivobuccal sulcus free, bilateral gingivolabial sulcus also free, buccal mucosa normal, floor of mouth normal, protrusion of tongue normal, retromolar trigon normal, the hard and soft palate are also normal. This is the examination of oral cavity. Palpation, skin around the ulcero-proliferative lesion. There's no localized increase in temperature, but induration was present. Tenderness over the lesion is present. All inspectory findings with respect to site size, shape, and borders confirmed. Hard in consistency, base is indurated. In mandible, no thickening or bony irregularities. Gingivolabial or gingivobuccal sulcus free. Examination of the lymph nodes. There was a single mobile non-tender lymph node of size 2 cross 1 centimeter in the left level 2 cervical region. Systemic examination, CVS S1 S2 plus, respiratory system bilateral air entry plus, parabdomen soft bowel sounds plus, and no palpable organomegaly. CNS no focal neurological deficit. Spine and cranium normal. Diagnosis, it's a case of carcinoma of lip involving the left half of lower lip and left commissure and upper lip lateral border with ipsilateral level 2 cervical lymph nodes. TNM staging T3N1M0. It's a stage 3 disease.
Did you tell about any pre-malignant condition in the oral cavity in this patient?
No,
Did
sir.
you
The
find
patient
anything on
didn't
the
have
inspection or palpation?
No, let's see examination. Yeah, your slides like not local cavity.
I didn't mention any, sir, because the patient didn't have it.
No, Dr. Tamil Mozi, just make it.
Yes, sir.
They're too small for me to read. You get me?
One
Too
second.
small. Okay, anyway, let's leave it like that. No, what is important? You must find out whether it is arising from the gingivo labial sulcus, gingivo buccal sulcus, and moving out, or is it from outside moving in? And how will
Yes,
you
sir.
do that?
Evert the lower lip and look for any growth
Yeah, so
inside
have you seen
the.
it? Have you seen
Yes,
that?
sir. Yes,
So
sir.
where have you written? Ulcer-proliferative growth size as a lower lip involving the left angle of mouth. No, is it involving the sulcus, gingivobuccal sulcus? or
No, sir,
gingivolabial sulcus?
no, sir, it didn't involve the gingivolabial sulcus, sir. I examined it, but I have not mentioned it in my history, sir.
Yeah, it's important, no? Because if she's leaving liquid, then just can make it. We can make it smaller, please. Yeah. If she's keeping her quid there,
You
Yes, sir.
gingivobuccal sulcus
gingivobuccal
is
and the
free.
gingivolabial sulcus free.
Yes, sir. Yes,
It's
sir.
not involving that at all.
Yes, sir. I have an image, sir. I will just show.
Yeah, let's have a look.
Yes, sir. Once.
Let's get the image.
Yes, sir. One second.
Okay, we'll take your examination. We'll go on by your examination. Okay.
Yeah, yes, sir.
Okay, that's fine. So you think this is CA lip
Yes, sir.
involving the commissure of the mouth?
Sir,
Now, is the upper lip also involved? Is it involved
yes,
in
sir.
commissure?
The lateral border is involved,
So
sir.
it is involving the upper lip also
Yes, sir.
and the commissure,
Yes, sir.
right?
Yes, sir.
And does she have all dentations? The left premolar seem to have been gone here, or they're still there. Okay, okay,
She has too
that's
many
fine.
caries, but it's present.
Okay, that's fine. Okay, just remove it. Okay, now what will you do?
On the face, you can see here. No, you can see few lesions on the face.
Yes,
on the
sir.
right side. What are those lesions?
Yes, sir. So it might be any patches due to
What are those dark things called because of sun exposure?
melanoma.
The actinic
Actinic
Solar
keratosis.
keratitis, right?
Solar
keratosis
keratosis.
may be there, yeah.
Solar keratosis, right?
Okay.
Okay, next slide, please. Localized increase in temperature is not important here. You think this is exposed to the environment. You think there will be localized rays? No, it's not important. Don't do it for every case. Localized raise temperature. In duration where?
Okay.
How far? How far from the lesion is the induration? Is the induration going down into the gingivobuccal sulcus? Dr. Taimoi? Hello?
Okay, sir.
No, just induration where?
Sorry, sir. Gingivobuccal sulcus.
No, induration where? How far is
Sir,
it extending?
induration. Sir, it's around 1 centimeter around the lesion, sir.
Okay. Is induration very common here, or where is the induration common? In which part of the oral cavity is induration much more common?
In
CA tongue.
buccal. Okay.
Buccal is not very common induration. Okay.
Okay. Okay.
Okay. What's the size? Look, you can't confirm the size. Don't write this confirmed.
Okay, sir.
Hard inconsistent base. Where is it lying? Is it involving the lip through and through? Is it involving both the surface? Or is just involving the pupilline border and finishes there?
Yes, sir. It doesn't involve the chin and all, sir. It's around the vermilion border only, sir.
Okay. Okay, next slide. Okay, so
Yes.
L2, okay. What is L2?
N2, sir.
Level 2. Which lymph nodes are there?
Level
Which
2
level
is
is?
level 2 is upper jugular, sir. Upper jugular, anterior, posterior. This node was
Submandibular, 2A and 2B, right?
2A, sir.
2A, okay. Okay. So your diagnosis is carcinoma lip involving
Yes, sir.
left half of the lip, upper
Yes, sir.
layer. Okay, that's fine. Okay.
Yes.
So what will you do now?
Sir, I'd like to investigate routine blood investigations, CBC, RFT, LFT, and serum electrolytes, random blood sugar, and VCTC viral markers, and
What is
incision biopsy of
VCTC?
the growth.
What is VCTC?
Sorry, sir. HIV, sir. Serology, HIV.
Triple H. No, what do you mean? What's the full form VCTC? I've never heard of this. What is VCTC? What's the full form?
No, sir, actually, it's a viral counseling testing center for HIV. We used to say it's VCTC. Sir.
Please use the terms
Common
anagrams which
term.
are right.
Yes.
So you
Sorry.
do a triple H marker, no?
Yes,
Hepatitis
sir.
B, C, and HIV.
Yes, sir.
Which other
HPSAG,
viral markers
HCV.
important? Which other viral markers important?
Sir, the HIV and HPSAG.
Is it important here? Or
But for
papilloma
this
virus viral
HPV
marker
is
is
more
important?
involved.
Right. So
HPV is more
you say
involved.
that, no?
Yes, sir.
Okay. You've taken an incisional biopsy.
Yes, sir.
From where? Which? Show me the point where you taken. Let's go to the photograph. From inside, from outside to the left, to the medial side, to the lateral side. Where have you taken it from? Where was the
Sir, from
incision
the
biopsy taken?
from the center of the growth, avoiding the
So
scab.
you'll take it from the medial towards the midline or towards the commissure. Where will you take it from? Or from the middle of the thing on the lower border, also the inside of the mouth. Where has the incisional biopsy taken?
Sir, the middle of the growth.
Middle of the if you take it right from the middle of the growth,
Medial.
you'll get.
Can you
So
show it
will
the
you take it
marker from where it has taken? Just show
will
it
you
the
take it from the
marker.
middle of the lip to on the medial side, from the commissure, from the mid, on the lower, from outside or from inside? 4 sides.
Sir,
Which one will you take?
sir, from the medial side of from the
No,
midline to
you'll
the
not.
medial side of the growth.
You will not. We don't want to cross the midline, no?
Yes, sir.
You'll take it from the outside in the middle of the. You just invert the lip and take it from the inside here, outside from the outside portion. Okay, next slide.
Okay.
Let's go back to that. So have you got the biopsy report?
No, sir.
Next slide. Have you got the biopsy report?
No, sir, not yet, sir.
Okay. What about lymph nodes? What will you do about that?
Sir, we can do a wide local excision with wide local
No,
excision of the
lymph node.
Sir, we can go
You will
with
do a local
left
excision of the
MR
lymph
and
node.
yes, sir.
No.
We have
You
to.
will do a. Will you do a excision biopsy of the lymph node?
No, sir, not necessary, sir. We can go with the neck node
No. It's
dissection.
not. I'm talking necessary or not necessary. Will you do it or not do it? You tell me.
No, sir.
Why don't you do it an excision biopsy?
Sir, oral cavity cancer spread is mainly through lymph node only, sir. So we can do an ultrasound neck for want to check whether the node is a reactive node or
Dr.
uh,
Tamemozi, my question
sir.
is, look, what kind of biopsy will you do for a lymph node? An FNAC or an excisional biopsy or a core biopsy?
FNAC can be done.
No, can be done. So you can even do an excision biopsy.
FNAC.
Okay, why don't you do an excision biopsy?
There can be other subcentrimetric nodes also present in the.
No, because when you're going to do a neck dissection, this is going to distort the planes. Okay.
Yes.
So ultrasound of the neck. What did you do? Why did you do that?
There can be any synchronous lesion in the thyroid or other
You think when there's a obvious malignancy in the lip, you'll think of a malignancy in the thyroid also. Two different malignancies. Why do you get an ultrasound done?
Sir, to look for any subcentrimetric nodes and
Right. There may be lymph nodes which are not palpable, right?
yes, sir.
What about an orthopantograph? What's an
What are the ultrasound findings of a positive lymph node?
Sir, the hilum architecture will be distorted, sir.
Hilum architecture, what is that? It is hilum or this?
Hilum
what
of
are the ultrasound findings of a malignant lymph node? What is the normal shape of a lymph node?
There will be round.
So normal is bean shaped. It will become rounded.
Yes, sir.
Then what will happen? The hilum will be lost.
Yes, sir. Hilum architecture will be lost, sir.
Right. And then there will be an halo around it.
Okay, sir.
And it will be taller than wider.
Taller than wider.
Right.
Hypercoagulation.
Right. Sir, please.
Look for the vascularity of that.
So increased vascularity will be present.
Yes. So all these are the findings of a positive, and definitely the size of the lymph node which is there.
Yes, sir.
So why you want to do a CT neck here?
Sir, to look for any bony involvement and adjacent vital structures involvement, vascular structures involvement. Sir.
So do you think the bony involvement will be there in this patient when you are doing the C's neck? It is to find out the lymph nodes.
Okay, sir.
Okay, it is mainly to find out the patient has got one lymph node. So you want to see if there are any other lymph nodes which are there positive or not. Because your treatment may change according to that.
Yes.
So when you are going for the lymph node dissection, it may change according to.
Yes, sir.
So that's why you want to do the CT neck.
Yes, sir.
And why X-ray the chest?
Sir, to look for any lung metastasis.
Is it very common to have the lung
No,
metastasis?
sir. No, sir.
What is the
And
chance
will a
of
chest X-ray show you bits? What is done
sir.
for
chest X-ray will just show.
You've got a CT,
CT
do a
just
CT test.
Yes, sir. CT thorax only will show the lung mets, sir.
Any role for triple endoscopy?
Sir, in nasopharyngeal carcinoma, it's a oropharyngeal carcinoma. If we can do a triple endoscopy.
In field cancerization, when you think that there's a large area involved,
Yes, sir.
it could be going down below also, so you do that is indication.
Yes. Okay, sir.
So how do you know on histology it is a squamous cell carcinoma?
Keratin pulse will be present, sir.
Okay. Are they always present?
Suppose
No,
it's
sir,
not
but
present.
most of it.
Suppose it's not present.
Okay, sir.
Then what does it tell you?
Widening of the reti ridges will be present.
It tells you that this is grade 4 undifferentiated,
Okay, sir.
right?
Okay, sir.
Okay. So when you take a biopsy, you do the grading and you do the
Yes.
depth of invasion also.
Yes, sir.
And you do the neurovascular invasion also,
Okay,
right?
sir.
Because in lip,
Okay.
it is very common to have neurovascular invasion.
Okay,
Right?
sir.
Yeah. So,
Okay. So the biopsy has come out to be it's a grade 2 squamous cell carcinoma.
Okay, sir.
Will you proceed?
Sir, wide local excision with a margin of 1 centimeter with a left MRND can be done, sir.
no. Hang on, Dr. Tamil Mozi. You're
Yes,
straight away going for surgery. Look, these are cases which has to be discussed in the tumor board. As
okay.
a surgeon, you can standalone surgeon. You need a lot of people. Who are the people in the tumor board now?
Sir, anesthetist, surgeon, pathologist.
I've not heard of the anesthetist, but maybe. Both are important ones. Most important one is the surgeon. Then
Surgeon, pathologist,
pathologist job is done.
radiation oncologist.
How will you reconstruct? You need a plastic surgeon, right?
Yes, sir, plastic surgeon.
You may have to involve a dentist, a radio oncoradiologist, an oncologist, a speech therapist. All these people
Okay.
have to be involved.
Okay, sir.
So,
So when you do the wide excision 1 centimeter here, how much
Yes,
is
sir.
the loss of the lip? Because then
Sir,
you have
it
to
will
reconstruct
be
it.
more than 50% will be lost, sir.
And you have to also excise the upper lip also. So commissure will go,
Yes, sir.
as well as the
Commissure
upper
with
lip will also go.
so you will do 5 millimeter margin with how much depth? When will you do a 5 millimeter margin? What is the grade? How will you decide on grade and depth to the margin? Is there a standardization that the depth is so much and the grade is so much, so it takes so much of the margin? So 0.5 centimeter margin is taken when the depth is 0.5 millimeters and this grade 1 or 2. It's grade 3 or 4, you have to take more. You
Okay,
get me?
sir. Okay, okay, sir.
So please.
Then, and what type of the block dissection you're going to do?
Sir, sorry, sir. Neck node dissection can go for MRND. MRND can be done, sir. Left MRND can be done, sir.
So if the CT scan has been done and there are no lymph nodes in the lower part, then still it is always required to go for the MRND.
Otherwise, we can do selective neck node dissection, sir.
So what type of the selective neck node dissection can be done here?
Sir, supraomohyoid neck dissection
And that
can
includes
be done, sir.
how many level of the lymph nodes?
Sir, level 1 to 3 with submandibular gland will be removed, sir.
What is modified radical neck dissection? What do you understand by that?
Sir, MRND usually will remove 1 to 5 nodes with removal of the sternocleidomastoid, IJV, submandibular gland and spinal accessory nerves. So that's classical. Will spare spinal accessory nerve in MRND type 1.
Sorry, Dr. Tamil Manmosi,
Yes,
do you
sir.
do this classical R&D?
No, sir.
Why?
Sir, too many vital structures are being removed, so
So
it's
which is the
better to
most
preserve.
vital structure? Which is the most vital structure which you leave,
Sir,
or which has to be left?
sternocleidomastoid.
Spinal
Sternocleidomastoid.
accessory. Spinal accessory nerve. That's the one which causes, if you remove, causes most
Okay.
morbidity, and it doesn't help in the outcome, right?
Okay, sir.
So what are the muscles which are supplied by the spinal accessory nerve?
Sir, trapezius, sternocleidomastoid.
Only these two here.
Yes.
Okay. So what is type 1, type 2, and type 3 type of the MRND?
Sir, in type 1 MRND, level 1 to 5 nodes are dissected. We'll preserve spinal accessory nerve, sir. Other four are sternocleidomastoid, IJV, and submandibular gland are removed, sir. Type 2 will preserve spinal accessory and IJV, sir. In type 4, type 3, only the submandibular.
In type 2, look, in type 2, you preserve the sternocleidomastoid and the spinal accessory.
Yes, sir.
Okay? Yeah.
Yes, sir. And type 3, sternocleidomastoid, IJV, and spinal accessory are preserved.
All
Sir.
three are preserved.
Yes,
Only
sir.
submandibular gland.
Yes, sir. Removed, sir.
So what is the difference between doing a MRND on the left side and the right side?
There is a lymph node involvement in the right side, then we can do a bilateral MRND, sir. Otherwise,
No. What is the difference between right-sided MRND and the left-sided MRND, or radical neck dissection as such? What is the difference between the left side and the right side? Any structure which is there on the left side, which you may damage, and then it can cause a problem. Thoracic duct is there. No?
thoracic duct, okay, sir.
On the left side, you get the thoracic duct, and that is likely to be damaged, and the patient may
Right
have
side,
right.
Okay.
What are the
Okay,
types of
okay.
incision you make for the block dissection? What are the types of the incision you know?
Sir, incisions. Sir,
2-flap dissection, 3-flap dissection, 4-flap dissection, Hayes Martin, Kryles. No?
okay.
You know who's the first surgeon to do a neck dissection?
Sorry, sir. I don't.
Cry. Okay.
Cry. Okay. Okay. Sir.
Yeah. Okay. What about radiation and chemoradiation?
Sir, it's squamous cell carcinomas, radiation therapy is necessary. Post radiation, it's necessary. Sir. I mean, post surgery.
So in lip, not involving the gingival, just the lip, external beam or IMRT is very, very commonly used. Okay.
Yes, sir.
Can you go for the brachytherapy here?
Yes, sir. Brachytherapy, the tumor exposure to radiation will be high, sir. So it can be given, sir.
what you will do for the lymph nodes there?
Lymph nodes.
Preferred treatment for the lymph node is always the surgery.
Okay, sir.
Preferred treatment, but we will also give the radiation for that, but preferred treatment is always the surgery.
Okay, sir.
So how will you reconstruct the lip in this patient after you have done the excision?
Sir, this patient, we can do nasolabial flap. Otherwise, deltopectoral flap or forehead flap. Those are the flaps can be done to reconstruct the lower lips.
Yeah, so you have to give the patient the cover and the lining both.
Yes.
So whatever the flap you are using, you have to provide. Either you use one flap or you use the two flaps for that. You have to provide the both because the support is not required here. You know?
Yes,
if it is involving the mandible and all, then you require the support for that. But here you just require the lining and the cover.
Lining and the cover.
Okay, Dr. Rajiv, can we say?
Yeah, I think we've done enough.
Yes.
Dr. Kanavel, sir.
Yes, sir. Yes, sir. Dr. Tamil, do you have any doubts to clarify, ma'am?
Sir, how to decide on whether the patient is fit for doing a supraomohyoid neck dissection or MRND? How to segregate the patient on
Supraomohyoid is usually the prophylactic type, you know.
Okay, sir.
Like if the patient is having it, carcinoma, the tongue is there, the floor of the mouth is there, there is N0 node is there, there are no nodes, then you can go for the prophylactic. But otherwise, say the therapeutic one, it is usually the modified radical neck dissection.
Okay.
Right. So if supraomohyoid is negative, then probably it will not have spread to other lymph nodes. Right. So when there are no nodes, you do a supraomohyoid to see if there are micromets there. If they are there, then you do the total. Otherwise, just leave it there and follow up.
Anything else?
So, Professor Khanna.
Yeah, I think we can. Dr. Kanayol, can we stop now?
Yes, sir. Yes, sir. Yes, sir. Think both the cases were a little long only. Maybe I'll try to next time limit 2 short cases or 1 long case alone, sir.
One long case is fine. It
itself took half hours.
Yes.
So we will work on that, sir. Thank you very much, sir, both of you for staying back for doing the second case. And thank you, Tamil Modi, and thank you, Arnav, for presenting the cases today. And thank both the respective faculty, Professor Sinha, sir, and Professor Saravanan, sir, for kindly permitting the candidates. Next week, we have a case of epigastric mass, possible pseudocyst, and one more case to be confirmed. Thank you very much, sir. With the permission of
well done, Tamil, well done, Dr. Tamil. Very well done.
Right. Thank you, sir.
Okay.
Good luck, Tamil.
Thank you,
please
sir.
found the areas where you found difficult. Tomorrow itself, you go and refresh your knowledge on that grounds. That will make you more safer and complete when you present the next time. Good luck to you. So, with the permission of the faculty,
Thank you. Good night, everyone.
Close and call it closer. Thank you very much, sir. Thank you.
Good night.